Look at the distal ends of the radius and ulna in this radiograph. We expect to see sharp, well-defined growth plates in a healthy pediatric skeleton. Instead, we see blurred, jagged borders where the bone is actively failing to maintain its structure. This is rickets. It is defined strictly as the failure of osteoid, the unmineralized organic bone matrix, to calcify at the growth plates. Because this failure occurs specifically at the growth plates, before epiphyseal fusion, rickets is entirely unique to children and adolescents. When this exact same mineralization failure happens in adults whose skeletons have already fused, it manifests differently and is diagnosed as osteomalacia. While there are several genetic and renal causes, the vast majority of cases stem from a nutritional deficiency in vitamin D. This usually originates from a lack of exposure to ultraviolet B sunlight or a diet lacking in fortified foods. To understand how a simple vitamin deficit leads to the severe skeletal deformities associated with the disease, we have to trace the breakdown of the body's vitamin D calcium axis and examine the self-destructive compensatory mechanisms that follow. Rickets is a dynamic mechanical failure of growing tissue, driven by a hormonal rescue system that sacrifices the skeleton to save the cell. This pathway diagrams the baseline endocrine axis, starting with vitamin D entering the system through dietary intake, or when UVB rays convert cholesterol in the skin into vitamin D3. It then travels to the liver, where 25-hydroxylase adds a hydroxyl group to create 25-hydroxyvitamin D. From there, it moves to the kidneys. Here, 1-alpha-hydroxylase performs a second hydroxylation, finally creating 1,2,5-dihydroxyvitamin D, the active hormone. This active hormone has one primary job: traveling to the intestines to maximize the absorption of dietary calcium and phosphate, delivering them into the bloodstream. When an infant has dark skin pigmentation, which naturally blocks UVB, or is kept fully covered indoors, that initial synthesis in the skin is cut off entirely. Without that starting material, the entire downstream pathway collapses. The growing skeleton is immediately deprived of the raw mineral materials it requires for basic structural integrity. Looking at this pathophysiology chart, we see the immediate consequence of that collapsed supply chain: a drop in serum calcium below the body's homeostatic set point. The parathyroid gland detects this drop instantly. To prevent fatal hypocalcemia, it triggers a state of secondary hyperparathyroidism. Parathyroid hormone, or PTH, floods the system. It signals osteoclasts to begin mobilizing calcium directly from the existing skeleton, pulling it back into the bloodstream to restore serum levels. At the microscopic level, these osteoclasts go into overdrive. They actively dissolve solid, healthy bone matrix, releasing the stored calcium directly back into the bloodstream. There is a secondary trade-off. While PTH saves calcium, it acts on the kidneys to cause massive renal phosphate excretion, a condition known as phosphaturia. Bone mineral is primarily hydroxyapatite, which requires both calcium and phosphate. With phosphate being dumped into the urine, the body completely loses its ability to mineralize new bone matrix. The body ruthlessly prioritizes serum calcium levels to maintain nerve and muscle function, keeping the patient alive at the direct expense of their skeletal stability. The cellular reality of this mineral deficit is severe. Growth plate cartilage and osteoid continue to multiply and expand, but without calcium and phosphate, they cannot calcify. They accumulate into thick, soft, disorganized layers. This softness creates the classic radiographic triad. First is metaphyseal cupping, where the compressed growth plate edge changes from a convex to a concave depression. Second is metaphyseal fraying. The sharp border disappears, leaving a blurred appearance where the osteoid refuses to harden. Third is metaphyseal splaying. Notice how the ends of the bones are abnormally wide. This happens because the structurally compromised growth plate is literally buckling and spreading outward under the longitudinal load of the child's muscles and weight. These X-rays provide a direct visual record of mechanical failure. The bones are literally yielding to gravitational pressure. That same mechanical failure causes the pathognomonic physical signs seen in clinical practice. The ricketic rosary occurs when the costochondral junctions widen and splay, creating a visible and palpable row of nodules along the chest wall. Just below that, we see Harrison's groove. The ribs are so soft that the negative pressure from the diaphragm pulls the lower ribs inward. This carves a horizontal depression across the chest during inspiration. The most profound warping occurs in the lower extremities. Once a child begins walking, the softened femurs and tibias are subjected to massive weight-bearing forces. The bones bend under the weight, resulting in either a varus deformity, known as bow legs, or a valgus deformity, where the knees collapse inward. In some cases, patients develop a windswept deformity, an asymmetrical collapse characterized by a varus bow in one leg and a valgus knock in the other. Every visible manifestation of the disease, from the bowed legs to the indented ribs, is simply normal gravity acting on a chemically compromised architecture. Because we understand the parathyroid rescue cascade, the expected clinical laboratory findings can be deduced purely through logic. Reviewing this lab panel for vitamin D deficiency, serum calcium is often normal or slightly decreased. Secondary hyperparathyroidism actively mines the skeleton to keep this number stable. However, because PTH also causes kidneys to excrete phosphate, serum phosphorus levels are predictably low. Alkaline phosphatase will be elevated. This enzyme is a marker of high bone turnover, reflecting osteoblasts desperately trying to lay down mineralized bone. And parathyroid hormone will also be significantly elevated, confirming it as the primary engine driving this compensatory response. This feedback loop lets you read the lab profile as a narrative of the body's physiological priorities, rather than a list of values to memorize. Treatment requires immediately reversing the chemical deficit. The child must receive high doses of vitamin D, alongside adequate dietary intake of both calcium and phosphorus. To ensure adherence, clinicians frequently use STOS therapy, administering a single massive dose of hundreds of thousands of units of vitamin D over a single day. A strict orthopedic protocol exists for physical deformities. Surgical intervention is almost never performed until the metabolic bone disease has completely chemically healed. Only after the bone hardens will surgeons address severe, permanent warping. They may perform corrective osteotomies, cutting and realigning the femurs and tibias with internal plates, as seen here. For complex deformities, surgeons may secure the realigned bone segments using external fixation devices, gradually adjusting the architecture from the outside as the limb heals. Recovery mirrors the pathology itself. You cannot fix the structure until you extinguish the biochemical fire and provide the minerals needed to rebuild the foundation.